Hello and welcome to today's talk on semaglutide and tirzepitide, medications that have been helping a lot of people with type 2 diabetes, but more recently have been all over the media for their weight loss properties, leading to a lot of misunderstanding and controversy in the public as well as with many physicians and other clinicians. I'm Dr. Jeffrey DeSarbo. I'm the medical director of ED180 and a psychiatrist specializing in the treatment of eating disorders here in Long Island, New York. The majority of my practice is usually focused on treating anorexia nervosa, bulimia nervosa, binge eating disorder, and bariatrics and general psychiatry. As a psychiatrist, I'm not only involved in the psychopharmacological management and treatment arm of patient care, but I also practice psychotherapy. I usually work as a team approach, working with other psychotherapists, nutritionists, physicians, and other eating disorder clinicians. Today's presentation is on the medications semaglutide and tirzepitide, prescribed under the brand names of Ozempic, Wegovy, and Mounjaro, and others, which are in development. Currently, right now, there's a few coming out, or at least they're testing some others that have a very similar mechanism of action. Semaglutide is a GLP-1 agonist medication most commonly used for its treatment in type 2 diabetes, but more recently it's been in the spotlight as a medication for weight loss, causing a lot of controversy, misunderstanding, questions, and significant shortages of the medications at times for the people who really need it, who are trying to manage their diabetes. So we'll briefly look at these medications from all perspectives, including their use in diabetes, as a weight loss drug for the medical definition of obesity, and their potential impact and fallout with the eating disorder population, as that's the area I'm quite familiar with and I hear a lot of it about. When looking at any serious issue, any types of reductionist thinking is never a good approach. This black and white thinking approach is neither appropriate nor beneficial when trying to understand complex topics, especially when they involve medical and psychological consequences for an individual. Medications such as semaglutide and tirzepitide have their place when they are used properly. Unfortunately, some celebrities out there have been open about their weight loss effects, and social media took off, followed by the mainstream media jumping in on this topic, further promoting, often exaggerating these medications as breakthrough miracles, often never mentioning the potential complications and possible side effects when misused. Let's not forget these are medications and they should only be used in very specific situations after a thorough medical evaluation, and especially if for weight loss, a thorough psychological evaluation. So the medications Ozempic and Wegovy are generally known as semaglutide, whereas Mounjaro is generally known as tirzepitide. They are both primarily GLP-1 agonist medications, which stands for glucagon-like peptide 1. However, Mounjaro is also a receptor agonist of GIP, which is gastric inhibitory polypeptide, thought to complicate the effects of the GLP-1 with decreased food intake and increased energy expenditure. It's not to say that it's a better medication, just that it acts slightly different, but still its main effect is ultimately through the GLP-1 receptor. In the body, glucagon is a peptide hormone that's secreted by the pancreas that does the opposite of insulin. It increases the concentration of glucose and fatty acids in our body when our serum levels are too low. Glucagon-like peptide is composed of about 30 amino acids. It's secreted by the intestines in the brainstem, and it's mediated by the vagus nerve, acting as an incretin hormone, which reduces blood sugar levels after we eat by stimulating the release of insulin and blocking that glucagon secretion. We'll see that in a second. So semaglutide is similar to GLP-1, but it has two modifications in its amino acid sequencing. First, at the 8th amino acid position, it's modified to block an enzyme DDP4, which reduces the body's clearance of the semaglutide. It keeps it in the system longer. Secondly, at the 26th position, it's modified so the medication binds to serum albumin, which again makes it last longer in the body. With tirzepitide, you can see it affects the GLP-1 as well as has this dual action in that it tirzepatide is actually an agonist at the GIP-1, which inhibits gastric emptying. There's an analog to the human GIP hormone with a fatty acid portion that's attached, and this kind of increases its optimal uptake and metabolism of the compound. So let's look at the mechanism of action here. The GLP-1 receptor agonist has primarily three mechanisms of action that play a role in managing diabetes and leads to side effects of weight loss. So when someone eats, blood sugar levels rise, and the small intestine releases GLP-1 as well as a similar release in the brainstem. This has a few effects. Firstly, GLP-1 reduces gastric emptying by inhibiting peristalsis in the stomach, and it increases the tonic contractions of the pyloric region via the vagal nerve. So food stays in the stomach longer, creating a prolonged feeling of satiety or fullness within the individual. Secondly, in the brainstem, the release of GLP-1 decreases appetite, working on several brain regions, especially the hypothalamus, which is our body's physiological command center, essentially, and on the solitary tract nucleus, which has numerous GLP-1 binding sites and receives taste inputs. It regulates the peristaltic activity of the upper GI tract during swallowing, and it modulates the response to different equilibrium changes. Finally, GLP-1 secretion stimulates the secretion of insulin from the pancreas, and it simultaneously suppresses the secretion of glucagon. So these are the primary mechanisms for how the drug helps manage type 2 diabetes and also how it leads to weight loss. Tirzepatide, in addition, has that effect again on the GIP, which is stimulating increased insulin secretion. However, the human body is a complicated organism. For instance, many people forget that adipose tissue or fat actually acts as an endocrine organ. That's why when an individual has any extreme change in the composition of their body fat index, it can affect multiple body systems, including the cardiovascular, musculoskeletal, and reproductive systems, as well as others. Adipose tissue is responsible for regulating a multitude of cytokines and neurohormones that, when in deficiency or excess, it can have these deleterious effects, and it needs to be understood from both a medical and a psychological perspective. Here we see that GLP-1 receptors are found throughout the brain, and for the purpose of this talk, I won't get into all of them. However, it is important to note that these varying brain regions are responsible for regulating a multitude of brain and body functions as well, and the full effect of GLP-1 in all of the brain centers is not fully understood. Now, we know that how GLP-1 works, but let's move on and talk about some of the side effects of these medications. Before considering starting any medication like this, one should meet with their medical provider to assess for the appropriateness, as there are some very important contraindications for using these meds, and patients need to know and understand this. Firstly, the medication should not be used in anyone with a history of thyroid cancer or multiple endocrine neoplasia, and it is not for use in insulin-dependent or type 1 diabetes. It must also be assessed carefully for use in anyone with a history of kidney or gallbladder disease or cardiac conditions and diabetic retinopathy. And anyone who has this active eating disorder process should also be considered a relative contraindication for the use with these conditions, with these types of medications. Not only can a medication like these potentially lead to increased risk of medical complications in individuals with eating disorders, but the psychological impact can worsen eating disorder pathology, and without proper screening can lead to the relapse of patients recovered from an eating disorder, and sometimes even cause the onset of an eating disorder in those prone to those conditions. I'll talk a little bit more about this in a minute. This slide again shows some of the common side effects that have been reported and need to be monitored for by your medical provider. Many of these are rare, of course, but as you can see, many can also be serious and life-threatening. And again, it's a medication not to be taken without careful consideration. Unfortunately, people hear weight loss, and it can be amazing how deaf they can become to hearing about side effects and risks. Just easily not wanting to understand what could potentially happen. So any medical provider prescribing these types of medications should go over the potential side effects of these meds and also let patients know what to look for in order to recognize the symptoms of these side effects. With the pancreas, you have to pay attention to any severe pain in your stomach that will not go away. Are there any visual changes? Let me go back. Is there hypoglycemia, which is rare, but it can happen? You want to monitor for signs of dehydration that can cause kidney problems, allergic reactions, swelling of the lips, face, tongue, gallbladder issues, pain in the upper stomach on the right side, yellowing of the skin. So it's important that people fully know and understand these potential side effects. But again, just because something has a potential side effect, it doesn't mean it's all bad. It's always a risk versus benefits when we make decisions in life, especially when we consider medications. The use of GLP-1 agonists in patients with type 2 diabetes has been shown in large meta-studies to reduce the risk of all strokes by 16%. They reduce major cardiovascular events by 13%, and it even reduces the cause of all mortality by 12%, in addition to helping manage their type 2 diabetes. Also, these medications have been shown to help other conditions, such as non-alcoholic steatohepatitis and neurodegenerative disorders like Parkinson's and Alzheimer's disease. So that's things to think about. Quality of life with a body mass index. So I believe the area in between the medical and the psychological impact of issues related to the medical definition of obesity are the issues related to a person's quality of life. However, how are a person's ADLs or activities of daily living, including things like getting in and out of bed, taking a shower, using the bathroom, the toilet, walking, using stairs? How much help does a person need? Do they feel dependent? Are they embarrassed or lack funds to hire help when needed? IDLs are instrumental activities of daily living, and they include things like the ability to use an automobile and drive themselves to appointments, to friends and stores. Can they shop and prepare foods for oneself? Can they clean their home? How does weight affect participating in life? Does it limit participation in life, in family events, sports, going on vacations, activities that require movement? Is it difficult to get into and out of a car? Are they comfortable fitting into an airline seat, or are they embarrassed needing to book a double seat? Limiting participation leads to isolation, and that can have a lot of unintended emotional fallout. So we have to look at those things as well. Also, is there any visceral and physical pain and discomfort? Visceral pain is very common and occurs when our internal organs are inflamed, diseased, damaged, or injured, and it's by far the most common type of pain. Other pain can occur secondary to the stress weight may place on joints in the skeletal system, or that can arise secondary from things like falls, accidents, and just transferring positions. So medical and therapeutic clinicians should carefully evaluate how obesity affects social isolation as well. Does one avoid leaving the house, either because they are embarrassed to go out or they're physically unable to ambulate without significant assistance? Social isolation can be a leading cause for depression and hopelessness. Isolation can lead to few friends, fewer interactions with family, and fears of intimacy. Obesity often decreases one's interest in sexual relationships, and even when that's in the context of marriage. So all of these types of quality of life stressors, and these are just a very few, can lead to some difficult issues with mental health, not limited to depression, social anxiety, loneliness, and other conditions that sometimes become self-medicated with things like alcohol or illicit drugs or other behavioral issues or addictions. So before we move on to the concept of eating disorders, we can understand that these medications do have risks associated with them, even when used appropriately for conditions such as type 2 diabetes. Let's not forget this is a medication that was developed, again, for type 2 type 2 diabetes, and it's been very beneficial for this patient population. Unfortunately, for many people dealing with this serious medical condition, the available supplies of these drugs have been in shortage, affecting the treatment of their diabetes in lieu of those who are seeking weight loss. Hopefully, this is just going to be a temporary situation, but that still remains a problem as of the time of this recording, and it's yet to be seen. These medications, like I said, they can make a significant difference in the lives of those who do have type 2 diabetes by improving morbidity and mortality, reducing the number of medications an individual might need to take, and that reduces medication-related side effects. They can reduce diabetic-related surgeries and amputations and improve the overall quality of life. As type 2 diabetes can often be a chronic condition in most, there can develop both a physiological and psychological dependence on these medications with significant consequences should one stop using them. And in patients without diabetes, the risk-reward measures also change, as we do not know the long-term side effects of using semaglutide or tirzepitide in those without diabetes. Many clinicians are not familiar with the concept of eating disorders, as they are mostly seeing their patients who often have disordered eating. So this slide is just a reminder of the difference between the two, and it's a major difference between the two. Without getting into a full discussion on what separates the two, these are kind of 5 key points known as the 5 Ds of what differentiates disordered eating from an eating disorder. Both that they're different, deceptive, debilitating, devastating, and deadly. And a person with an eating disorder has a mind that suffers beyond obsessive thoughts related to food, weight, body image, calories, exercise, and other types of related issues, along with this internal voice that is extraordinarily demeaning and self-berating in most instances. In fact, the common thing I share and how I kind of manage and follow one's treatment with an eating disorder is the question, what percentage of your free thoughts and your free time do you spend thinking about, worrying about food, weight, body image, calories, exercise? And when somebody is in an acute state, in a serious condition with an eating disorder, the response is almost all the time, 90% of the time, 100% of the time. And we look with treatment to reduce that percentage. Whereas disordered eating, there may be some patterns that may not seem to be the healthiest or most functional, but it's not this all-consuming process that kind of takes over an individual. So we have to be extra careful when thinking about the use of these medications in a person with an eating disorder or who may have had an eating disorder, been prone to it. One of the bigger concerns is that, again, we don't want to exaggerate or make somebody who may be prone to developing eating disorders such as anorexia nervosa or bulimia or binge eating disorder kind of have an exacerbation of these types of symptoms. So like some other medications currently available, semaglutide or tirzepitide could become an additional method of misuse to alter food intake and manipulate weight in somewhat irresponsible and often dangerous manners. We have already seen an almost addictive pattern of drug seeking for these medications, and in some severe cases of eating disorders with obsessional weight loss drives, people will, use deception again to try to get their hold on these medications. The use of these meds can not only exacerbate restricting behaviors with food, but they can also mask some eating disorder behaviors with bulimia and binge eating disorder by reducing some of the physiological symptoms, but never addressing the underlying psychological processes that drive eating disorder behaviors. Eating disorders, of course, are associated with a multitude of related comorbidities and increased medical risks when adding a medication such as semaglutide or tirzepitide can complicate and increase these risks in the eating disorder population. And to make matters worse, many patients do not report their eating disorder behaviors and symptoms to their primary care doctors and other clinicians, and prescribers sometimes miss this important information and can easily be misled into prescribing these types of meds in a clinical setting. The risk of psychological and physiological dependence is even greater with the eating disorder population because their use is primarily for that appetite reduction and weight loss, and these weight loss effects mostly cease the moment one stops taking these meds. This can be just a completely unacceptable thought when someone is suffering with an eating disorder mindset, and individuals can often become desperate to make sure this doesn't happen. And those with diabetes, if this medication needs to be stopped, there are alternatives available to treat the diabetes, but may not have the weight loss and is much less likely to cause a panic attack because of that. So finally, some people may be genetically prone to develop an eating disorder pathology, but we often say they need this trigger, this epigenetic trigger to set an eating disorder in motion. And the use of these types of medications can sometimes be the type of trigger where someone starts to become obsessed with weight loss and body image and actually leads to the onset of full-blown eating disorder, which may have been kept at bay for a while. In the field of eating disorder treatment, there's an even greater sensitivity to issues with eating disorder patients. From a therapeutic and mental health perspective, clinicians in the field are cautious about treatment approaches and dialogues that may be insensitive to many who struggle with body images and issues, with body shaming kind of being at the forefront. The general rule is an acceptance that one feels healthy at any body size. That goal is to be healthy despite weight and body shape and to be appreciative of one's own body at any size. And I'm all on board with that approach as a goal, but then there is a medical reality that is often playing itself out, at least not immediately, but some people do in fact have medical conditions that have to take medications to protect their health and well-being. In this large meta-study of nearly 3 million individuals, the results indicate that the death rate was significantly higher for all grades of obesity with a BMI greater than 30. Now, the term obesity is also a controversial word in some therapeutic circles, but is still the medical term used when medical clinicians, and for the purpose of this presentation, needs to be considered, again, for medical health and overall well-being. Thus, medical doctors and the therapeutic clinicians, they have to really work to develop an approach to protecting a patient's physical health when it's in jeopardy, while also learning more to be sensitive to the psychological effects related to especially self-acceptance and self-esteem. Something that I, again, working as a physician, know as, probably many people just watching this know when we go into the doctor's office, there's little sensitivity around speaking about our weights and what we need to do to medically to feel better with some of these conditions. So when evaluating a patient for the use of medications like semaglutide or tirzepitide, I believe it's important to use a prudent, conservative approach. Make sure there's no eating disorder present. The doctor-clinician must ask about the potential existing eating disorder signs, not just signs of disordered eating, but of a true eating disorder, which usually consists of asking about how much thought process, as I mentioned, one puts into things like, again, the weight, body image, calories, exercise, dietary restrictions, use of diet pills, compensatory vomiting, excessive exercise, or anything else extreme that someone may use to try to control their weight. Are there any signs of obsessive thoughts or compulsive behaviors related to food or body image? Again, these should be big red flags. This is a medication with its own set of risks and side effects, and exactly how medically necessary is this medication? Is the patient on other diabetes medications that could cause an interaction, or are there other better options? You want to check with other medications the patient may be on for interactions, or uncover other medical conditions as a patient may have failed to report or indicate a contraindication to using these types of medications. Do a thorough exploration with the patient as to realistic risks and benefits of using any of these types of medications, including potential side effects, both the minor ones and the potential serious ones, and evaluate their expectations for what they hope the medication will do. With any serious or chronic medical condition, it's not a bad idea to support patients by asking about their support system. If they have a psychotherapist or a nutritionist, or this almost certainly should be a requirement if one is seeking these medications for weight loss to avoid treatment failure and minimize the risk that it can be associated with their use, including the onset of eating disorder behaviors. Glucose, weight, body mass index monitoring should be responsible and often in both patients with type 2 diabetes and patients without diabetes. Again, close medical monitoring is required not only for the effects of the medication, but also for the risk of developing any of the more serious potential side effects. So just to kind of sum things up, when discussing things with patients, it's important to have an accurate assessment, full medical, psychological evaluation, thorough weight, food, diet history. Make sure you look at family medical and psychiatric history. There's the psychological sensitivity, assess any mental health state on conditions that may be potentially existing. Rule out any eating disorder risk. Again, relative contraindication from my perspective. It's a big red flag. Assess the history of body shame and body image distress, distortions, another big red flag. Is there any history of trauma, functionality, the quality of life? How are those things? And again, expectations. Someone who's saying, I want to get on this med. I heard on television the celebrity used it and lost 70 pounds, and that's what I'm expecting. There has to be a reality check and probably much more of a psychological evaluation. Again, where's the medical necessity for this? There's are there other related medical conditions that are going on related to the diabetes or obesity? It's a family medical history. Going over again the short-term and long-term potential risks of both using the medications and the risks of not considering them. Will any change in the treatment of something like diabetes or morbid obesity reduce potential other medications that may having some bad effects on a patient's overall health and well-being? Any history of lifestyle changes that has been a result of their medical condition. Again, kind of going over those expectations, and the clinician prescribing it should make sure that they have realistic expectations and also understands when it comes to the weight loss perspective, stopping these meds is likely to result in 90 to 100% return of any body weight loss due to the medications. And there should be this comprehensive plan. It should be looked at as a team approach. Physicians, therapists, nutritionists, group support, stress management, lifestyle change. I list all of those. And the thing is, if a patient has this comprehensive plan, whether they're dealing with their type 2 diabetes, if they have all of this, or they're dealing with morbid obesity, it's something that to really improve someone's both quality of life and outlook on their long-term physical well-being, a comprehensive plan and team approach is going to be their best bet. Whether or not one decides to use these types of medications or others ultimately will come down to that physician and patient decision. It is a medication, and it has to come down to that good contact, good communication between the physician and the patient. So again, thank you for listening. I hope this helps explain a little bit about these two medications. I just tried to give a brief overview of basically how they work so people can understand what they're doing. Of course, I encourage others who, especially medical clinicians and professionals, to delve deeper into the mechanisms of action, and those who are in the field of eating disorder treatment just to take into consideration that, sometimes we're working really hard with the patient psychotherapeutically, that we might sometimes forget to really think about the medical necessity of some treatments, not just for physical conditions, but also we need to work on improving an individual's quality of life. Some of my contact information there. And again, thank you for listening.